Hey guys, welcome back. The next topic we're studying is systemic sclerosis, which is also called as scleroderma. And you know that rheumat is one of the most sought after branches nowadays, and that's because it's highly paying as well. And with that enormous amount of money a rheumatologist is going to be making, he will have to be very systematic about filing his income tax returns. Otherwise, the taxman would come knocking. And I'm going to today use a mnemonic to describe the manifestations of systemic sclerosis, that is systemic ITR. And let's look at the manifestations here. And the first one that I'm going to write is going to differentiate this from all other connective tissue disorders in MCQs as well as in clinical practice. That's going to be skin tightening and skin thickening. In fact, because of this skin tightening and skin thickening, one of the early manifestations that would develop in the case would be loss of transverse creases. Like we all have these creases present on our interphalangeal joints. And if you look at the first image where I'm putting the white arrow, you will notice that in this person, there is a complete loss of the transverse skin creases. And then the skin thickening and the skin tightening will continue. It will start from distal, go to proximal, then will involve even the face of this patient, even the trunk would be involved. And in fact, in the later part of the stages, the extensive amount of skin thickening that is present can be responsible for contractures, which could be flexion contractures in the hand. And therefore, if you look at the second image, you can notice that claw-like appearance of the hand. And the term that's used to describe this claw-like presentation would be referred as sclerodactyly. So I can say that at this moment, I've covered two features of the disease where we're keeping the Y alphabet silent. And then the next thing that has to be remembered is telangiectasias. Well, where would you be checking for these telangiectasias? They would be present on the cheeks, on the lips of these patients. I'll be showing you an image of these telangiectasias as well. But at the moment, I would like you to remember that these telangiectasias imply vasculopathy, microangiopathy, damage to small blood vessels in these patients. And in fact, the number of telangiectasias has been found, or the severity of telangiectasia is directly proportional to the severity of pulmonary artery hypertension as well. Then even the GI tract is involved in this condition, fibrosis synchronously affecting multiple body organs. I mean, that's the easiest way I can make you remember this condition. The extensive fibrosis in all organs occurring at the moment is in the intestine, and that would explain the manifestations of esophageal dysmotility. There would be decreased tone of the lower esophageal sphincter. This will also cause GERD and reflux esophagitis. And because the gut motility in this condition would be hampered, it would be slower because of the fibrosis occurring in the gut. Therefore, another manifestation, that is the alphabet M, would come up, would be malabsorption syndrome. And therefore, weight loss can also be explained in these patients. Diarrhea can be explained in these patients. Then the next reason that I'm writing, that is alphabet I in systemic, is one of the main reasons why these patients would be dying. And this interstitial lung disease subsequently responsible for development of pulmonary artery hypertension. So in most of the cases, it is a combination of interstitial lung disease and pulmonary artery hypertension, which results in death in these patients. Alphabet C would stand for calcinosis, that would be calcium deposits in the skin, and this calcinosis cutis is occurring in a setting of normal calcium and phosphate levels. Well, then what is the calcinosis composition here? It would be answered by you as calcium hydroxyapatite. I'm going to write calcium hydroxyapatite in the later part of the discussion, but at the moment, just sensitizing you to the fact that unlike in patients who are having CKD or patients who are having hyperphosphatemia, where calcium and phosphate will chelate, and then you could be having calcium deposits in the skin as well. But at this moment, it is calcium hydroxyapatite for the calcinosis part. Then alphabet I would represent that there would be immunological abnormality seen. And one of the most important immunological abnormality, the villain antibody behind development of this autoimmune condition, would be called as anti-topoisomerase antibody. In fact, in the later part of this discussion, I'm going to talk about total of 9 antibodies seen in systemic sclerosis. But one of the key words in the question that would be present would be one, skin thickening sclerodactyly, another one would be topoisomerase antibody described. And the amount of fibrosis in this condition can be occurring, I mean, the amount of fibrosis and the extent of fibrosis can be so extensive that it could be even involving the tendons. And that is why we can be hearing, we are having audible tendon friction rubs in these patients. Traditionally, we read pleural rub, we read about pericardial friction rub, but today I'm teaching you about tendon friction rub. That's because of the contracture, that's because of the fibrosis, that's because of the calcification that would be occurring in the tendons. And then alphabet R would be standing for whenever this patient, who's mostly going to be a female patient, as all rheumatic disorders are more common in women. So every time she's going to be putting her hands in cold water, there's going to be change in the appearance of the tip of the finger. First, there is going to be an exaggerated vasoconstriction, so the tip of the finger will become wide. Then the stasis of blood here and the ischemia of the tissues will cause the tip of the finger to be appearing blue, that is cyanosis, and subsequently there would be redness appearing, and this would be associated with pain and discomfort as well. So Raynaud's phenomenon will also be encountered in these patients, and that's again a very good point. Raynaud's phenomenon, in fact, the pointers that I'm saying is topoisomerase antibody, though all of these features have to be remembered by you, but then skin thickening, Raynaud's phenomenon, topoisomerase antibody, even tendon friction rubs are like very characteristic manifestations seen in this case, which if written in a question would just scream out loud that the diagnosis would be systemic sclerosis. There are various forms of this condition as well, like we'll describe about diffuse cutaneous systemic sclerosis, limited cutaneous systemic sclerosis. So I'll subdivide into the various subtypes that we see as well, but that would be just a quick overview with respect to the kind of things that we'll be discussing in the next about quarter of an hour with respect to manifestations of systemic sclerosis. And in the later part of this condition, you could also be having atrophy of the skin, and that could contribute to ulceration on the extensor aspect of the finger. So where you're noticing this black arrow present, this is going to be a ischemic digital ulcer that would also be seen. Though ischemic digital ulcers would be relatively more common with the limited cutaneous systemic sclerosis variety, but then you could be having this initial presentation of loss or transverse creases, and then at the same site in the same patient at a later point of time, you could be having ischemic digital ulcers as well. In fact, in some cases, they can be even gangrene and a necessity of amputation in these patients as well. Therefore, let's now focus on the pathology behind the development of this disease. Before I speak about the antibodies, let's look at what is the fundamental problem. And the main problem in these patients would be answered by you as vasculopathy, or I can say microangiopathy. I mean, traditionally, we read the word microangiopathy with diabetes mellitus, but today I'm teaching you an autoimmune disorder that's going to contribute to vasculopathy or microangiopathy. So what's happening from a pathology perspective is, what is this antibodies causing? These antibodies are one causing the replacement of the endothelial cells by mesenchymal cells. I said a big thing, guys. Blood vessels are getting affected. The inner lining of the blood vessels are getting affected, and there is endothelial cells which are going to be replaced by mesenchymal cells, which means that multiple organs would be affected. The blood supply of these organs would also be affected. Like one of the important organs that is affected in this condition is the kidney. So in the later part, like I'll be talking about scleroderma, renal crisis, but I just wanted to give you a heads up that endothelial mesenchymal transition implies that renal circulation or renal blood supply is hampered. That will decrease the GFR, that will cause a higher renin hypertension, and therefore high blood pressure or accelerated hypertension would be a manifestation with respect to scleroderma, renal crisis. And one of the histopathological findings that we'll see in these patients would be onion skin appearance. Then, as I explained, there's a thickened dermis. In fact, loss of sweat glands can occur, loss of sebaceous glands can occur, and that loss of sebaceous and sweat glands is responsible for that shiny appearance of the skin. In fact, this disease would be more common in women between 65 to 75 years of age. And because the skin will become stretched, the wrinkles in these patients will decrease. I mean, traditionally, as we get older, the wrinkles in the skin will increase. But in scleroderma, there is a rather decrease in the wrinkles. That's because the skin is stretched and shiny, because there's a fibrosis that is occurring, along with atrophy of the sweat glands as well as the sebaceous glands. Then there's a big problem that will contribute to death, that is interstitial lung disease, and GERD, gastroesophageal reflux disease, that occurs in these patients because of fibrosis in the lower esophageal sphincter, is a risk factor for development of interstitial lung disease. And ILD would contribute to shortness of breath. We'll have to use specific drugs that I'll be describing for management of this condition. And on long-standing basis, if there is going to be interstitial lung disease, there will be hypoxia. Hypoxia always causes vasodilation of all blood vessels in the body. Mark my words there. Hypoxia will cause vasodilation of all blood vessels in the body. Like if you go to high altitude like Leh or Ladakh, hypoxia will cause vasodilation of your brain blood vessels that will stretch the nerve endings related to the dura, and therefore headache can occur. So hypoxia dilates all blood vessels except pulmonary artery, and because pulmonary artery would be affected in this condition, that is a vasculopathy component is also there, plus hypoxia component is also there. So the combination of the two, that is hypoxia by interstitial lung disease, because there is fibrosis developing in the lungs. In fact, from the pathology perspective, one of the subtypes of interstitial lung disease that is common in this condition is non-specific interstitial pneumonitis. Traditionally, you are aware that we have UIP variant. In fact, I would suggest you to listen to the interstitial lung disease topic subsequently in RESP also. But even if you're not, you are aware from pathology that the UIP variety, the usual interstitial pneumonitis variety, is more common than non-specific interstitial pneumonitis. But today in the topic of systemic sclerosis, I'm teaching you guys that it is NSIP variety that is more common than UIP. Then there would be pulmonary artery hypertension due to combination of hypoxia and vasculopathy, and the kidneys would also be affected. The kidney involvement would be written in MCQs because nowadays integrated questions are coming. So he may not write the word scleroderma, renal crisis, or in one of the options he may not write accelerated hypertension, acute kidney injury. He might just write that traditional pathology term, fibrinoid necrosis of the renal vessels, that is a fibrinoid necrosis of the arterioles, and this is the one that I was speaking about earlier as a onion skin appearance. Though I mean onion skinning per se is we see with multiple conditions, so I'll not go into those at the moment. I'll just say one casual one, like Ewing sarcoma. We read about onion skin appearance with respect to diaphyseal tumor on an X-ray, but today we're talking about a blood vessel in the kidney that explains accelerated hypertension and a possible reason for mortality. In the era when ACE inhibitors were not available, then scleroderma renal crisis was one of the important reasons for mortality in this condition. But as of now, with the advent of ACE inhibitors, well, the chances of mortality due to scleroderma renal crisis would be lesser. Scleroderma renal crisis per se is less common in patients of scleroderma. It's not that all patients would be having scleroderma renal crisis, but majority of patients would be having interstitial lung disease. So on a I would say percentage of cases that get affected, overall I said the leading cause of death would be a combination of interstitial lung disease and pulmonary artery hypertension. Now, as far as the heart involvement in these patients is concerned, there can be multiple reasons why the cardiac output of this person can be affected, and one of them is that there is fibrosis in the myocardium, and therefore there would be a diastolic malfunction in the heart. The heart would behave like a patient of restrictive cardiomyopathy, that would be elevated left ventricular end diastolic pressure, elevated right and diastolic pressures, and therefore if the end diastolic pressures will rise, they would be contributing to congestion in the lungs and congestion in the peripheral circulation as well. Over and above this, the fibrosis can be affecting the conduction system of the heart, and therefore no big deal that we could be having sick sinus syndrome developing in these patients as well, a prolongation of PR interval in the ECG that is seen. And while I describe those heart blocks, at the same time, don't be under impression that only bradyarrhythmias would be seen in this condition. Even tachyarrhythmias can be seen. In fact, just like lupus, even scleroderma contributes to increase incidence of atherosclerotic cardiovascular disease. And in older patients anyway, the CV mortality is on the higher side, and then this disease would increase that cardiovascular mortality. Even the outside of the heart can be involved. All the three layers of the heart can be involved. It could be myocardial fibrosis, it could be endocardial fibrosis, and important, even pericardium can be involved. Because of that, there could be auscultatory finding of pericardial friction rub developing in these patients. They might be development of chest pain episodes. You might be thinking it's a myocardial infarction. It might turn out to be a pericarditis as well. And because of this pericarditis, even pericardial effusion can be picked up on the ECG. They could be low voltage ECG. They could be electrical alternance. And if the amount increases, it could also contribute to hemodynamic collapse in these patients as well. Then apart from the heart involvement, tendon sheath involvement is present. As I've explained, even in the earlier part, there would be tendon sheath fibrosis present plus minus calcification. And as a result of this combination of the two, whenever the particular muscle which is attached to the tendon is being used, we might be able to hear on use of a muscle audible tendon friction rubs. In fact, the case or the patient might himself describe that he can hear this sound whenever he is trying to move a joint. I mean, he will not be able to pinpoint the reason for that noise, but that crackling sound, that leather texture of The sound that is heard is a tendon friction rub, which is a peculiar finding in a sense that traditionally we read about pericardial and pleural rubs, but today I'm describing tendon friction rubs for these patients. So these 7 points basically give you an idea regarding that what is going to actually happen in a patient. And those clinical manifestations would, I can just sum up by saying that systemic sclerosis is a disease where there is a synchronous fibrosis affecting multiple body organs, and among the worst affected would be the kidney and the lungs, but it's usually the lungs which contribute to developmental mortality, along with the ILD and PAH aspect that I said would be occurring simultaneously in a patient or might be developing over a period of time, because traditionally you see interstitial lung disease will and pulmonary artery hypertension PAH will take some time to develop. If first has person has lung disease, no, traditionally in core pulmonary they teach us first we have a lung disease and later there is a pulmonary artery hypertension, but in this condition there could be simultaneously development as well. Why? Because there is a vasculopathy component that would be affecting the pulmonary small blood vessels as well, and that is why simultaneous development of ILD and PH can also be occurring in these patients. How in the MCQ will he be writing pulmonary artery hypertension? Let me give you a heads up here. He could be writing up terms like loud P2. I mean, he may not write pulmonary artery hypertension, but like I'm saying, integrated question. So one option could be talking about fibrinoid necrosis of arterioles and onion skinning. Another one could be talking about loud P2, or could be talking about functional tricuspid regurgitation, functional pulmonary regurgitation developing in these patients. Or he might even mention DLCO, that is diffusion capacity of the lung for carbon monoxide being lesser. So you just have to get used to that fact that it could be like onion skinning and a low DLCO described in this question. Or if there's going to be a myocardial fibrosis, he could describe elevated pulmonary capillary wedge pressure, filling pressures in the right side of the heart are getting affected. So elevated JVP can be described. Kussmaul's kind can be described in these patients as well. So it gives a lot of scope for the examiner to actually ask you a topic on systemic sclerosis, because multi-systems are getting involved. So he can be testing your knowledge of the involvement of, like, the features of PH I was speaking. Those are the ones, or the features related to myocardial fibrosis, elevated JVP, or the features that we read in restrictive cardiomyopathy could be incorporated in the same question as well. Now, having said that, I'll now be describing before you total of 9 autoantibodies that are seen in systemic sclerosis and would be causing these myriad manifestations that I've described on the previous slide from the pathology perspective. There are two ways this can be asked to you. One would be a theory-based question that he'll say which antibody is used to confirm the diagnosis of diffuse cutaneous systemic sclerosis, and your answer would be given as anti-topoisomerase antibody. Most of the time, these patients would be having extensive tendon friction rubs, interstitial lung disease, scleroderma, renal crisis, and in an integrated kind of a question, he might describe immunofluorescence study as well. Written on this immunofluorescence study will also be the word HEP2, which basically means human epithelial cells, which are derived from a patient with laryngeal cancer. They are put on a slide, and then you incubate the serum of this person with the HEP2 cells. And in case there is going to be antibodies against the various components like topoisomerase, centromere, or against any nucleoli, then this would light up, because immunofluorescent probes would be used and the whole sample would light up, and therefore you can see a very discrete pattern, but it would be so discrete. I mean, the fine green dots will be so closely linked to each other that the whole thing will appear homogeneous. And therefore, in case they give you an image-based question where you can see the first image, anti-topoisomerase antibody, it would be a discrete homogeneous pattern described. But in some questions, you will notice that when it comes to the nuclei of these cells, the immunofluorescent probes would be causing discrete pattern. Like at this moment, you can notice that the antibodies are localizing in this particular case to the centromere. Centromere is in the center of a chromosome, and that's where, I mean, the chromosome, has to attach to a mitotic spindle, and then the two parts of the chromatids will move separate during the process of mitosis. So it is the dots here are representing the centromeres, which are present in the nucleus of this cancer cell, which is being tagged with a fluorescent probe in this particular case. And in case they give you an image where you can see these green dots, but they appear as a discrete speckled pattern, then you want to describe the second antibody for this case, that is anti-centromere antibody. In the first one, the green spots are so close together that it's causing a diffuse homogeneous pattern. here because there are some gaps present between them. So that's why it has been described as a discrete speckled pattern, which is attacking the centromeres. That's anti-centromere antibody that is seen with limited cutaneous systemic sclerosis. And one of the variants of this is called as Crest syndrome. In fact, the features of Crest syndrome I'll be writing on a separate slide, but just giving you a heads up at the moment because these terms have been explained to you. Calcinosis related to calcium hydroxyapatite deposition, Raynaud's phenomenon, esophageal dysmotility, and then sclerodactyly, that claw hand-like presentation due to skin tightening, and loss of transverse creases in the dorsum of the hand. And T would be standing for telangiectasias, which would be seen on the face, on the lips of these patients. So you'll say mucocutaneous telangiectasias. The third antibody to be remembered would be called as anti-RNA polymerase 3 antibody. And for this one, the immunofluorescence study pattern would be slightly different in a sense that we'll call it a speckled nucleoplasmic pattern. And you will notice that the dots that I'm showing are identical to what I drew superiorly, but this time I've shown them relative to be of a thicker caliber as compared to the discrete speckled pattern that I've shown superiorly. So this would be called as a speckled nucleoplasmic pattern per se. So what you need to get a hang of is the patterns which are shown in the slide adjacent to it. ATA, that is anti-topoisomerase, anti-centromere, and then ARA, that is anti-RNA polymerase 3 antibodies. That's to be precise for ARA. And among that, though total, I'll be describing 9 antibodies before you, but then these top 3 are the ones which are to be given a top priority. Now for 4, 5, 6, you will notice that the names will begin by alphabet U, like it would be U3RNP. RNP stands for ribonucleoprotein, and then would be U1RNP. In fact, I'm putting a star because that's an important one to be remembered for the exam. And then would be U11 and U12RNP as well. So 4, 5, 6 all are having a prefix alphabet U present. And let's now complete 7, 8, 9. A bit of peculiarities here. Bear with the data here. The antibody would be called as anti-Ku antibody. The importance of this will also be shared before you. Then after anti-Ku, the next one to be remembered is TH by TO subset antibody. And the last one is PMSCL. This would be, PM would mean polymyositis, and along with that scleroderma manifestations would be described. For the U3RNP, you need to remember an alternative name as well, that is fibrillarin. And for the U1 RNP, the importance is that this person could be having concomitant, pulmonary artery hypertension anyway seen in scleroderma, but along with this, description of inflammatory arthritis will also be given in the question, and features of myositis would be given. You see, when I was describing features with that mnemonic, I did not say myositis per se, but now I'm incorporating myositis in the profile of the case as well. So the technical answer of yours on reading these features, which are the extra features that are given here, would be written as MCTD, that is mixed connective tissue disorder. The English word makes it easier. Mixed connective tissue disorder means that you're getting multiple manifestations. Apart from that, as scleroderma, you're also getting an inflammatory arthritis. You're also getting a myositis present in these patients. Another overlap syndrome which has to be remembered is the Ku antibody one. So I'll just put 2 star marks at the moment to highlight the overlap syndromes that I'm talking about at the moment. And as far as the Ku antibody is concerned, the overlap syndrome would be having features of SLE. That's very shocking, guys. In the MCQ, he will talk about skin thickening, he'll talk about sclerodactyly, Raynaud's phenomenon, digital ulcers, and you'll be thinking, okay, man, this is a question of scleroderma. And then he will describe features, some that are seen with SLE also, and then he'll talk about features of myositis as well. So this description that are basically given before you is called as overlap syndrome. And the data that I've highlighted at the moment, mixed connective tissue disorder, antibody name U1RNP, or the overlap syndrome with anti-Q antibody, these are the ones which are more important from the INISET perspective. So if you're preparing for FMJ exam, then all you need to remember is 1, 2, and 3. But if you're preparing for NEET PG as well as INISET, you need to remember the subsequent ones as well. Having said that, I'll just put another color coding here, which would be to highlight a speciality. That is, I put some dots for point number 8 and 9, and I've also put a yellow dot for U3RNP. These are the ones which are described to be having a nucleolar pattern of immunofluorescence studying. and all the remaining ones where the yellow dot is not present. Wherever the yellow dot is present, you will answer from the MCQ from integrated pathology perspective as nuclear pattern of immunofluorescence staining. And for all others where no numbering is present, you will have to remember that as a speckled pattern. Though even in the speckled, I described a few differences, like it was a discrete speckled pattern versus a speckled nucleoplasmic pattern where the dots are relatively much more denser in nature versus a homogeneous pattern for anti-topoisomerase. So I would rate this as one of the important slides from an integrated perspective. And the top three anyway are more frequently asked in all exams, but there is a possibility that he might even talk about these overlaps, especially with anti-Q antibody where features of SLE shockingly. I mean, he'll talk about features of scleroderma, then he'll talk about myositis and SLE features. And then even in U1 RNP, you saw that there was involvement of inflammatory arthritis and then the myositis component present. So those terms basically deserve the respect that they want. For PMSCL, again, I would like to say that the manifestations that we'll be seeing, though, I mean, it is obvious for PMSCL, but let's just do it for the sake of completion. I mean, what are the features that would be described for PMSCL antibody? We'll talk about interstitial lung disease, which I described earlier also. Remember, one of the risk factors for development of interstitial lung disease is GRD also, because micro aspiration of saliva could be developing in these patients. Then apart from ILD, calcinosis, cutis would be described. So far so good, nothing very surprising. But then the only thing is he'll start talking about myositis, he'll talk about proximal muscle weakness, difficulty in climbing stairs, difficulty in getting up from a toilet seat. So that myositis component, as you can see, whenever it is coming, that's where he's interested in knowing regarding the fact that regarding these couple of overlaps that could be occurring in these patients as well. Out of the descriptions that I have given from 4 to 9, max importance to be given to part number 5 and 7 because of the terms like these: U1 RNP antibody for mixed connective tissue disorder, and then anti-Co antibody for the overlap syndrome, where we have, I'm repeating that again so that I can emphasize that, cement that into your brain, features of scleroderma plus shockingly SLE and myositis. This part looks a little more, difficult to remember, and the table also is fairly, I would say, a moderately big table in Harrison, but overall from these it's possible that high yield questions would be asked with the due respect to be given to point number 1, 2 and 3 in this basic list. Next up, we'll focus on the spectrum of the disease, where he'll use terms like limited cutaneous systemic sclerosis, or he'll use diffuse cutaneous systemic sclerosis. In fact, the spectrum would involve DCSSC, diffuse cutaneous systemic sclerosis, LCSSC, systemic sclerosis, LC is limited cutaneous, DC is diffuse cutaneous, and then would be SSC, sign scleroderma. It basically means that features of scleroderma would be present. Fibrosis in multiple organs would be present, but this would be occurring in the absence of skin thickening, which I said was one of the hallmark features that differentiates systemic sclerosis from other rheumatic conditions or connective tissue disorders, but this would be absent in SSC, sign scleroderma. It is unlikely to ask you about this extreme right hand thing because still, once you read this term, absence of skin thickening, there's nothing much to ask. Remaining features of organ involvement would be present. It is DCSSC and limited cutaneous systemic sclerosis that should be remembered. So let's look at diffuse cutaneous one, where the disease will begin in the form of sclerodactyly. As I explained, will start from the distal areas, cause a claw hand-like presentation, and can go to involve the face. And because of the involvement of the face, patient could be having difficulty in opening his mouth also. Like imagine you have to bite into a big chicken maha burger. You need to open your mouth wide, but here because there would be fibrosis around the lips, therefore microstomia would be described for these patients, and then ILD and renal involvement would also be occurring. In limited cutaneous, the main clinical data that I want you to remember at the moment would be that the disease will start with Raynaud's phenomenon and sclerodactyly will be occurring after many years. In diffuse cutaneous variety, Raynaud's phenomenon and sclerodactyly could be occurring simultaneously. I'll repeat the data once again. If a question simply says, what is the commonest manifestation of diffuse cutaneous variety? Answer would be skin thickening, sclerodactyly. But if he says, what is the commonest manifestation of limited cutaneous, it's going to be Raynaud's phenomenon. Sclerodactyly will be present in both of them because after all, the disease is scleroderma. Highlight of that is sclerodactyly. But the difference between the two is the one to be remembered. And the difference to be remembered by you is that in limited cutaneous, the presentation of the disease is Raynaud's phenomenon. it is not that Raynaud's phenomenon will not be seen on the left hand side. It is the difference between how the disease is evolving. First Raynaud's phenomenon, after many years sclerodactyly. Whereas if both are occurring together, or the initial presentation is sclerodactyly and Raynaud's is occurring later, then we think in terms of diffuse cutaneous systemic sclerosis. Obviously, to solve the problem, like what are we dealing with, we will have to go ahead with tests also. That would be like topoisomerase antibody, which is valid for the diffuse cutaneous variety, and the limited cutaneous is anti-centromere antibody. And then we have a discrete subset also. I said about this verbally, just a quick look at this: calcinosis, then RP, Raynaud's phenomenon, esophageal dysmotility, which will contribute to GERD, and microaspiration of the acidic contents, which will promote the damage in the lungs. And then would be the classical feature of this condition, which will develop after many years, and then would be telangiectasia as well. So this is a subset that we encounter, and the antibody name that is to be remembered for the limited cutaneous variety is anti-centromere antibody, whereas for the diffuse cutaneous variety, the name to be remembered is anti-topoisomerase antibody. Having said that, I would also like to mention that ischemic distal ulcers, I mean, normally we read about uh, ischemic ulcers with respect to, or the ulcers in the tips of the fingers with even polyarthritis nodosa. So in the vasculitis component, even you will hear me once again talking about digital ischemic ulcers. But then even in systemic sclerosis, I have said the same thing. The locations would, however, be different. That specifically for scleroderma, the ischemic distal ulcers would be located in over the interphalangeal joints, where initially the transverse creases were getting lost. Now, having said that, let's now focus on a couple of image-based data related to this. And the most common extracutaneous manifestation of this condition would be change in the tip of the color of the tip of the finger on especially exposure to cold or to vibration or even emotion. That would be Raynaud's phenomenon, for which we might have to use calcium channel blockers, and in some cases even alpha blockers would be required. Another feature that would be seen in these patients is the fibrosis on the face, as I was saying. Then I did not yet see this, but at the moment I am describing pinched nose or pinched faces that is described for these patients. And even if you look at the lips of this patient, they look to be tightly approximated because there's fibrosis around the lips as well. And that is why I was saying that if this person will have to bite into a big McDonald's Maha burger, person is not going to be able to open mouth. That is microstomia. The same microstomia is even much more visible. You can see the fibrosis occurring in the skin, which is causing a slight puckered appearance of the lips, and they appear tightly, I would say, close together. And even the face of the patient might be having an expressionless appearance. I mean, traditionally we read about expressionless appearance or expressionless face in, or mask-like faces in Parkinsonism, but that expressionless appearance will occur in these patients also because of the fibrosis that will occur on the facial musculature. In fact, the forehead of these patients might even lose hair as well. The wrinkles will become relatively lesser initially, and you might have that pinched faces or a pointed nose appearance as well. Then the next thing that you're noticing in these patients in the image-based series is telangiectasias. The telangiectasias would mostly be present on the cheeks, on the lips of these patients, and they're directly related to the severity of microvascular disease, including pulmonary artery hypertension. For the ischemic distal ulcers, I've already spoken about. And how do I pick up that this is unlikely? This can be polyarthritis nodosa as well. Even in polyarthritis nodosa, there could be involvement of the kidney. In fact, one of the commonest organs that is involved in polyarthritis nodosa would be kidney. But then the question will talk about aspects like hypertension present, absence of glomerulonephritis, which is one of the very characteristic features that we see in polyarthritis nodosa. So vasculitis question might be initially talking about ischemic distal ulcer as well, but other features that are seen in polyarthritis nodosa ranging from livedo reticularis as a presentation, that is fishnet appearance of the skin present, in contrast to the absence of the wrinkles or the stretching of the skin, would give you a hint with respect to whether you are dealing with polyarthritis nodosa or whether you are dealing with systemic sclerosis. The image on the right hand side again shows extreme, I mean, the way the image is, it shows extreme tightening of the skin, which causes that classical uh, appearance of the contractures of the fingers, and therefore a claw-like appearance of the hand can be seen, and that's why the term is sclerodactyly. These terms have been mentioned because all these in image-based format, because they could be a question where he could give you immunofluorescence and he could give you the clinical manifestations as well in the form of an image instead of just giving you theory, and then he could ask you to pick up the disease. It would relatively be an easy pick. I mean, you just need to pick up these immunofluorescence patterns that I mentioned along with the clinical profile, and you know that you're dealing with a case of systemic sclerosis. It will become a little difficult in the overlap syndromes, I agree. But as far as the standard diffuse cutaneous systemic sclerosis is concerned, that would be a piece of cake for anybody to pick up in questions. So let us now do an activity which is going to be summarizing the clinical features in a single slide. The disease being autoimmune is more common in women as compared to men. The question will describe a female patient and then will say anti-nuclear antibody positive. Now, anti-nuclear antibody is positive in SLE, that is okay, but this test is a screening test for even scleroderma. A lot of guys, when they start reading this question, female anti-nuclear antibody positive, they get a bias in their mind that the question is talking about only SLE. No, guys, you need to get out of the bias, because the features that I'll be describing to you subsequently are going to be different from that of SLE, like the age group, 65 to 74 years of age. And then certain features that I'll describe next before you are very specific for diffuse cutaneous systemic sclerosis. Like they could be shortness of breath, exertional dyspnea described in a question due to interstitial lung disease. Because of the heart involvement, there would be fibrosis. This would be written either as diastolic malfunction of the heart, it can be written as restrictive cardiomyopathy, and then we could even be having arrhythmias developing in these patients. I've already explained to you that the type of arrhythmias that can be seen here can be both bradyarrhythmias as well as tachyarrhythmias in these patients as well. Then they can be accelerated hypertension. There would be scleroderma renal crisis that would be described. This data that I've written in color red is a feature that is more common. I mean, the features that have been described at the moment are relatively more common with respect to diffuse cutaneous variety of systemic sclerosis. And now let us compare this with the features of limited cutaneous variety. And one striking difference that you will notice will be that this renal involvement is usually not seen or very rarely seen with limited cutaneous variety, but the renal involvement is more pronounced and is seen in about 15% cases of the diffuse cutaneous variety. For the limited cutaneous, the manifestations can be in the form of dry mouth. Again, he'll try to confuse you because we read about dry mouth, and then we read about dry eyes also, and then we read dry vagina for Sjogren that I'm going to discuss in the later part of the same video. So he's going to write xerostomia as well, but other features would differentiate because this is going to talk about microstomia, difficulty in opening the mouth because of the fibrosis below the skin, perioral skin per se, and microstomia is, we do not read about microstomia with respect to Sjogren syndrome, that will be discussed subsequently. Then due to the fibrosis in the intestine as well, the gut motility will be hampered. That can explain the malabsorption syndrome that's occurring in these patients. Then can be tendon friction rubs. They have been explained primarily because of the fibrosis and the calcification part. So it would be a very audible tendon friction rub, and then there can be development of flexion, joint contractures. But as I highlighted, I mean, the question is going to go on and on about fibrosis everywhere, but we'll usually talk about the renal involvement, which is less likely as compared to diffuse cutaneous, where the renal involvement is more likely. Let us now talk about features which would be common between the two. So the data in red is more common with diffuse cutaneous variety. The data in green is more common. I'll just write it also. The data is more common with respect to the limited cutaneous variety. And now we're going to talk about common clinical features between both of them. They can be remembered by BCD-GT. I mean, grand tests are the backbone of, I would say, your regular preparation. So you need to start giving them ASAP, as early as possible once you have completed 19 subjects. I mean, obviously giving a grand test before completing all subjects would not be as advisable, because once you completed that 19 parikrama of all 19 subjects, now you get a bird's eye view of the medical science as a whole. And then when you start giving grand tests, your performance would start increasing. So let's look at the manifestations, guys. You are going to be having GERD. So no big deal that GERD can cause development of Barrett's esophagus, and therefore esophageal cancer risk can be increased in these patients. Due to interstitial lung disease, lung cancer risk is increased. Due to Barrett's esophagus, esophageal cancer risk is increased, and therefore in patients with scleroderma, ESR will start rising. Usually ESR is normal in patients with scleroderma, but it starts rising in those cases where there is going to be an increased incidence of cancer. That's either Barrett's esophagus or lung cancer that will be seen with ILD. Then another feature that we notice is calcinosis cutis. This would be due to calcium hydroxyapatite, as I've explained. Then would be digital ulcers that would be seen on the extensor part. Then along with this, Raynaud's phenomenon would also be described, RP. And then another feature to be remembered would be GTs, the mnemonic, the remaining part, that would be GRD and telangiectasias. So though the same thing was shown in images also, what I've tried to do here is to talk about those kind of questions where he'll ask you that which manifestation is more common with respect to diffuse cutaneous versus the limited cutaneous varieties. And most of the time, the question that would be asked would be the one that I've already highlighted before you, that the renal involvement, the scleroderma renal crisis. On reading the word crisis, again, I find a lot of guys get tempted and they start thinking in terms of IV drugs being used for management of high BP. But here, exerted hypertension, BP would be in the range of about 150, 160 by 110. And we will use ACE inhibitors in these patients. Prior to ACE inhibitors, the mortality rate with scleroderma renal crisis was higher, but now the incidence with renal crisis per se in scleroderma contributing to death would be less likely in the scenario of the ACE inhibitors and the RAS blockade that we have, the highly effective RAS blockade that we have. Apart from this, another feature that I can mention for these patients would be development of salt and pepper appearance of the skin, especially in dark-skinned Indians. They can be hypopigmentation as well, and therefore, since there is loss of even appendages, the skin will appear very stretched and shiny. And then the salt and the pepper appearance of the skin can be a fact-based question as well, or a one-liner as they tend to ask in the NEET exam. So the current focus was to just summarize all the clinical manifestations of the disease in a single slide. Next up, I'm going to provide some bites with respect to Raynaud's phenomenon. This is going to be the most common extracutaneous manifestation of systemic sclerosis. The common sites where we're going to come across Raynaud's phenomenon is fingertip, but then do not be surprised if in the question he describes it at the tip of the nose or ends up describing it in the earlobes of the patient. Apart from the common trigger, that is cold exposure, he can also describe this Raynaud's phenomenon occurring with respect to emotional changes. And another trigger that I can say looks very peculiar when I say it the first time, that would be exposure to vibration. Like this lady is using some tool that is producing vibration, then again Raynaud's phenomenon can be triggered. The color changes would be white, blue, and red, as I said. And one of the tests that can be used to identify rather or visualize the nail bed of these patients for early diagnosis of systemic sclerosis is called as nail fold capillaroscopy. In fact, the pattern, because this disease is all about vasculopathy, it's all about microangiopathy. So this nail fold capillaroscopy should be remembered for two reasons. One, this is used to visualize the nail bed capillaries, and the changes in the nail bed capillaries will help in early diagnosis of systemic sclerosis. Another reason why we are using nail fold capillaroscopy is to differentiate between the primary variety and the secondary variety of Raynaud's phenomenon, because the pattern of those capillaries involved in primary and secondary Raynaud's phenomenon would be different. What I mean by primary would be, though you read about this in surgery as well, but let me just do my part. The primary part would mean the idiopathic variety, and this idiopathic variety is technically called as Raynaud's disease. So in a MCQ, he is going to use the term Raynaud's phenomenon of the secondary variety, because systemic sclerosis per se is a connective tissue disorder which is contributing to Raynaud's phenomenon per se. So the main point is that there are two terms which are to be remembered. One would be Raynaud's disease, and second is this term secondary Raynaud's phenomenon. I've written secondary Raynaud's phenomenon for the current disease that we're discussing, that is systemic sclerosis. In fact, a couple of endocrine diseases as well, a couple of hematological conditions as well. In fact, the next thing that I'm writing is just a miscellaneous description that this guy, he is a convict. He's working in a jail. He's using hammer to break big rocks, and therefore hammer hand is a term which is used to describe Raynaud's phenomenon in those patients where like they're using a big hammer to break the rocks, and every time he's gonna slam onto that big hammer into the rock, the vibrations that are produced is gonna trigger Raynaud's phenomenon. Or another description I can say from vibration perspective is that this is a guy, he's not suffering from scleroderma, he's simply a crane operator. and this crane is used to lift heavy duty weights. So he has to put his hand on the gear and change the gear to adjust the tension in the table in the cable, so that he can lift those heavy weights with the help of a crane. And the vibrations of the engine will be transmitted, or the vibrations will be transmitted to the gearbox on which he's keeping his hand, and therefore this chap can end up with development of Raynaud's phenomenon as well. So when do we say secondary Raynaud's phenomenon? Is when it is associated with the following disorders as I've explained. And if it is idiopathic, then we call it Raynaud's disease. In fact, even drug association should be remembered. One of the drugs that we use in management of ovarian cancer, that is stage 4 ovarian cancer, which would be causing metastasis to the peritoneum. There could be a malignant pericardial effusion. There we use cisplatin. So that drug is also incremented in causing manifestations of Raynaud's phenomenon as well. So I would say for this particular slide, it's very miscellaneous kind of a data. But two data that must be remembered from this slide is one, this nail fold capillaroscopy as an investigation for early diagnosis of systemic sclerosis. It is not as accurate as the antibody and the immunofluorescence studies that I've said, but yes, is a welcome to our arsenal of investigations that can be done for workup. And then the term primary versus secondary Raynaud's phenomenon also I wanted to say, because if he says Raynaud's disease, then he's not talking about association with scleroderma. That would be an idiopathic manifestation of change in the color of the fingertips to white, blue, and red. And most of the time, the drug that we'll be using would be calcium channel blockers, that we can be using prazosin as well. We can be using topical nitroglycerin for management of patients of Raynaud's phenomenon as well. Some more miscellaneous bites with respect to this topic, like in lung diseases, systemic sclerosis, there would be ILD and pulmonary artery hypertension. I've already explained GRD is a risk factor for development of ILD. And well, the important thing to be noted is that in the MCQ, he might write down a spirometric parameter, because after all, see what's happening in this chap is development of restrictive lung disease. So when do we say restrictive lung disease? We say restrictive when FEV1 FVC ratio value is going to be more than 0.8, and the FVC ratio of the patient is less than 70%. Contrast this with respect to COPD, chronic obstructive pulmonary disorder, where we talk about FEV1 FVC ratio less than 0.7, and then we talk about FEV1, which could be less than 80%, less than 50%, and so on. So in a large number of questions, he may not write interstitial lung disease, which I've been describing, and I've described those patterns like non-specific interstitial pneumonitis and UIP. He might just write the spirometric parameter. Another way to describe interstitial lung disease can be DLCO, diffusion capacity of the lung for carbon monoxide. DLCO can be less in interstitial lung disease as well. It can be less in pulmonary artery hypertension. Though for diagnosis of PH, I'll be checking some pressures that I'll be explaining to you. Apart from this, as I already explained, that if there is pulmonary artery hypertension, there would be loud P2, there could be murmurs that are functional murmurs that are developing, parasternal heave would be present, and we can demonstrate ILD in real time by doing a high resolution CT scan that will show subpleural reticular opacities. Now, what is the definition of pulmonary artery hypertension? It is mean pressure. Normal mean pressure in the pulmonary artery would be 15 millimeters of mercury. If it goes beyond 20, usually the range 20 to 22, that's we say pulmonary artery hypertension. The pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure is elevated in heart failure. But at the moment, there is no heart failure. So PCWP has been mentioned to be less than 15 millimeters. And then PVR stands for pulmonary vascular resistance. And the pulmonary vascular resistance, if it is more than 3 Wood units, that would be definition, technically appropriate definition of pulmonary artery hypertension. You see in a routine video, I'll just say pulmonary artery mean pressure more than 22 millimeter of mercury. That's one definition. But to make it sound more sophisticated, he can write these parameters, no? Why we are going in this slide is only for two reasons. That ILD in MCQ systemic sclerosis will be written as FEV1 FVC ratio more than 0.8. We know that in restrictive lung disease, the ratio is more than 0.8, less than 0.7 in obstructive. Second reason why he's asking this is for this complete definition of pulmonary artery hypertension. One way is obviously the standard DLCO being lesser, loud P2, but then other is these definitions that I mentioned with PCWP less than 15 and pulmonary venous resistance greater than 3 Wood units. Because there would be heart failure in these patients ultimately. So biomarker for heart failure, like we know TROP-I and TROP-T for myocardial infarction, it is N-terminal pro-BNP, that is B-type natriuretic peptide, which is elevated, because ultimately, if there's going to be pulmonary artery hypertension, the right side of the heart would be affected. Then as far as the renal crisis is concerned, there is a scleroderma renal crisis, which is treated with ACE inhibitors. The terms that would be described in MCQ would be accelerated hypertension, Exalted hypertension simply means a high renin hypertension, and due to high renin, aldosterone would also be higher, and therefore these patients would be having more salt and water in the body along with metabolic alkalosis. Why metabolic alkalosis? Because aldosterone would be causing urinary loss of hydrogen, and thereby metabolic alkalosis would be present. Along with this, the person will go into acute kidney injury, and the incidence of scleroderma renal crisis is higher with, earlier I was telling you renal involvement is more common with the diffuse cutaneous variety. Now I'm telling you an association with an antibody. Pay attention to this, guys. In one of the earlier slides, we had discussed that the renal involvement is more common with diffuse cutaneous. Now you need to remember the renal involvement is also more common with anti-RNA polymerase 3 antibody. Along with this, obviously, there would be other features also present like leathery audible tendon friction drugs, and then he might even describe anemia and thrombocytopenia. Why that anemia and thrombocytopenia is occurring is because the small blood vessels of the kidney are getting affected, and therefore there could be development of microangiopathic hemolytic anemia. If you're not familiar with this term microangiopathic hemolytic anemia, you need to focus on a video that I've taken for a topic of TTP, thrombotic thrombocytopenic purpura. That's where I've talked about microangiopathic hemolytic. But that's, as the name suggests, you can solve by English here also. माइक्रो मतलब छोटा ब्लड वेसल, एंजियोपैथिक मतलब वो छोटा ब्लड वेसल में माइक्रो थ्रोम्बाई बन जाता है, एंड आरबीसी स्लाइस हो जाते हैं, तो आरबीसी का जो अपीयरेंस होता है उसको शिस्टोसाइट बोलते हैं. शिस्टोसाइट सब कहाँ पढ़ते हैं? तो हेमोलिटिक यूरेमिक सिंड्रोम में पढ़ते हैं, थ्रोम्बोटिक थ्रोम्बोसाइटोपेनिक परप्यूरा में पढ़ते हैं, और अभी हम स्क्लेरोडर्मा में पढ़ रहे हैं. वाई? बिकॉज माइक्रो एंजियोपैथिक हेमोलिटिक एनीमिया इज द ट्रिगर. दे वुड बी, इमेजिन देयर इज अ mesh of microthrombi in the blood vessels, and then when the RBCs will smash into those mesh, it will get sliced into half, and that is when the damaged RBC can be present. The biopsy finding has already been enumerated. That would be onion skinning appearance. So you can see that once again I have just invested a few minutes extra into the renal involvement, because onion skinning, exalted hypertension is okay, but then I added metabolic alkalosis also. I also added association with anti-RNA polymerase 3 antibody, and I also said that because these patients are more sick, so you will notice these patients having anemia and thrombocytopenia. It looks very surprising because prior to this I did not mention any hemat association. I never talked about any anemia and thrombocytopenia in this scleroderma topic. This is because of the microangiopathic hemolytic anemia due to the involvement of the renal vessels in these patients. The vasculopathy that occurs in the renal blood vessels is responsible for this, and there's microthrombi formation also, which contributes to these schistocytes. Then the cardiac involvement would be myocarditis. There would be fibrosis in the heart. And the reason why I have spoken about it again is because in the exam he simply asks what is the best way for diagnosis of myocarditis. There are two ways to diagnose myocarditis. One of them is the traditional way, endomyocardial biopsy. The only problem is it is invasive, and you might actually miss the site where the inflammation is present because the myocarditis might be focal as well. So as of now, if he says in the exam, overall, for any myocarditis, whether it is COVID-19 myocarditis, whether it's going to be myocarditis occurring due to any connective tissue disorder, cardiac MRI is always to be given a priority over endomyocardial biopsy. That aspect has to be remembered, because in earlier times it was like when I was a student, and even a couple of years back, for myocarditis it was always about Dallas criteria. It was always about the gold standard word even today. Gold standard word even today would be an endomyocardial biopsy. But if he says overall what is the best test, IOC means high sensitivity, high specificity, and practical also. Gold standard test may not be practical. It's an ideal way when you tell a patient is going to run away and may not be ready for it. So the additional bites which have been provided, I'll just say them once again. Spirometric parameter, restrictive lung disease, definition of pulmonary artery hypertension, the addition of the antibody association in this particular case with schistocytes that can be written in MCQ, because traditionally schistocytes हम पढ़ते हैं तो you think in terms of hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, but then even scleroderma as an association with scleroderma is also to be remembered. And then for the myocarditis component, a miscellaneous fact was mentioned, that would be a cardiac MRI. These are a couple of details which I would like you to remember over and above the standard features that I've described. Plus, for the risk of malignancy, all I can say is that ILD is present, and then Barrett's esophagus due to GRD is present. So the risk of cancer, lung cancer, esophageal cancer is elevated in these patients. So traditionally ESR is normal in scleroderma, but in this case they can be elevated. If there is a malignancy, ESR will be elevated. There is no treatment available that will alter the progression of the disease. The drugs that are to be used in this condition are cyclophosphamide and methotrexate. As far as steroids are concerned, he says try to minimize the usage of steroids. Use whenever necessary. I mean, for steroids, he's not very enthusiastic, or is giving a thumbs down for steroids, is because they will worsen the renal crisis. I mean, steroids per se can worsen the renal crisis of these patients, because steroids themselves cause hypertension. No, and if the guy's BP is already elevated, then the BP will spike even further also. So he says use whenever required. Otherwise, drugs that can be used are cyclophosphamide, methotrexate, IL interleukin 6 antagonist, tocilizumab that was used in COVID cytokine storm, rituximab. Then nintedanib. This is a drug that is used in interstitial lung disease. It is mainly to reduce the progression of the pulmonary fibrosis that is developing in this case. ACE inhibitors will be used to control the high blood pressure, and nowadays, scleroderma renal crisis, as we explained, would not be too much of a challenge. And for Raynaud's phenomenon, then the drugs that would be used is calcium channel blocker, which is the first answer. Other drugs that can be used is like prazosin, sildenafil, then topical nitroglycerin, and even intermittent prostaglandin infusions are used for management of Raynaud's phenomenon. But then these, I can say from this particular slide, the main aspect to be remembered would be what I've written in the box, that is steroids can actually worsen the renal status of these patients from the perspective of renal crisis. I mean, I'm not saying it will worsen acute kidney injury. All I'm saying is it will worsen the hypertension status. So he says wherever possible, use it uh, as less as possible, and in a setting that alternative drugs are available, we can avoid using it as well. Next up, we'll talk about another connective tissue disorder, that would be Sjogren. Coming to the manifestations of Sjogren syndrome, the question will most of the time be describing a female patient with dry eyes, dry mouth, and dry vagina. Those words are very characteristic and help in picking up Sjogren syndrome. The pathological highlight of this condition is lymphocytic infiltration, and the disease has a tendency to involve the exocrine glands. The last time I ever said exocrine glands being involved mainly was for cystic fibrosis, but today I'm talking about lymphocytic infiltration of those exocrine glands. And therefore, since eyes can be involved in these patients, the lacrimal gland is involved. Therefore, dry eyes, or he might write the word keratoconjunctivitis sicca. Last time I mentioned keratoconjunctivitis sicca is in topic of rheumatoid arthritis. One of the ocular manifestations is keratoconjunctivitis sicca. And you also read about scleromalacia perforans in rheumatoid arthritis literature. But here other features will also be given, like dry mouth that can explain the halitosis, the dental caries that would be developing. A highlight of this condition is also that there is a profound B cell hyperactivity, and because of this, there can be increased incidence of two cancers. One of the cancer whose incidence is increased in patients of Sjogren syndrome is lymphoma. The treatment for this lymphoma would be like treating any routine lymphoma, but you just need to remember that increased incidence of multiple myeloma and increased risk of development of lymphoma is seen in patients with Sjogren syndrome. That's explained by profound B cell activity. Usually in the questions, he will also help you by mentioning the name of the villain antibodies. And this antibody that we usually encounter in this condition would be called as anti-Rho antibody. In fact, there are two subsets of these anti-Rho antibodies that also need to remember, that is anti-Rho 52, anti-Rho 60. Anti-Rho 52 is also described in SLE as well and explains the photosensitivity component. So you just need to remember these numbers, that is SSA antibody, anti-Rho antibody 52, anti-Rho 60. Another antibody that we come across is LA, that is La antibody, which is also written as SSB antibody. In earlier times in literature, they used to write terms like SSA and SSB. That literature can still be present in a couple of those questions if the examiner selects from the older database. But in the current edition, is mentioned these numbers specifically: anti-Rho 52, anti-Rho 60, and La antibodies. Those are the names to be remembered. As far as the female to male ratios for this condition is concerned, the number of female patients would outnumber men by a ratio of as much as 10 to 20 is to 1. And there is also HLA predisposition that is present. Most of these patients would be having HLA DR3. And along with this, I mean, these DR linkages are usually given in questions just to add the burden of the data that you need to remember. So HLA DR3, DRW52 are the HLA associations that you need to see. The test that we use for diagnosis of this condition in earlier times was salivary gland biopsy. I mean, we always used to read salivary gland biopsy is the best way for diagnosis of this condition. Even now, we will be doing a salivary gland biopsy, not of the major salivary gland, but it is mainly the minor salivary glands. But that alone is not sufficient for diagnosis of this condition. The test that I'll be doing in this case would be a labial saliva. We have to take a biopsy of the minor salivary glands. So a lymphoid infiltration of the labial minor salivary glands would be mentioned in the diagnostic criteria of this condition. And on my next slide, I'll be describing the algorithm that is recommended nowadays for diagnosis, where he talks about multiple parameters. I'll describe total of 5, and out of those 5, at least 2 should be present to say that it is a possibility of Sjogren syndrome, with one of the findings being minor salivary gland biopsy being done. That is a labial minor salivary gland biopsy showing evidence of lymphoid infiltration. I would like to reiterate that though the question can be solved by the word dry eyes, dry mouth, dry vagina, even dry trachea, but in the questions, I mean, those words like dry may not be repeated again and again. So let's look at the kind of vocabulary that the examiner will be using in this topic, expecting you to answer as Sjogren syndrome. One of the highlights of this condition, as I said, is dry eyes and dry mouth. But along with this, because of the lymphocytic infiltration, bilateral salivary gland involvement can be seen, or bilateral parotid enlargement can be seen. Bilateral parotid enlargement we also seen in alcoholics. If a person is having features of liver cell damage, there is alcoholic hepatitis progressing into alcoholic cirrhosis, then we read about parotid enlargement bilateral. Then we read parotid enlargement with mumps. We read bilateral parotid enlargement with sarcoidosis. But today I'm talking about that in a connective tissue disorder as well. Along with this, features of fatigue, low-grade fever can be described along with Raynaud's phenomenon. So yes, remember that Raynaud's phenomenon we were earlier reading in limited cutaneous scleroderma, even present in diffuse cutaneous scleroderma, but is also being discussed with respect to Sjogren. So that term has to be remembered. Then these patients can be having pain in the joints. That is, small joints of the hand can be involved. Traditionally, we read about pain in the small joints of the hand with respect to PIP, MCP, and wrist joint in rheumatoid arthritis. So, what I'm trying to point out is that in the question, when he starts talking about Raynaud's phenomenon, when he starts talking about even arthritis, there can be a doubt in the mind of a student that, okay, is he talking about rheumatoid arthritis? Is he talking about systemic sclerosis? But the remaining features that I've said, like a bilateral salivary gland enlargement that is seen in this condition, which is very pronounced salivary gland enlargement, would help you pick up that he's talking about Sjogren. The next feature that I say is important from MCQ perspective, that this disease can be causing involvement of even the kidney tubules, and therefore renal tubular acidosis can occur. Metabolic acidosis, yes guys, can be a manifestation of this condition. Either he'll talk about involvement of the tubules and then renal tubular acidosis, or he can talk about renal involvement in the form of MPGN. Last time we read MPGN is with association with hepatitis C, but today we're talking about MPGN in association with Sjogren syndrome, which has that classical dry eyes, dry mouth, dry vagina, and additional features which are being discussed at the moment. So you can see the importance here, like some of the features that I'm underlining at the moment will be written as features in the question to confuse your mind: ILD, arthritis of the small joints, and Raynaud's phenomenon. But apart from the ones which are marked right, the remaining features that I've written, that is, I mean, even if he doesn't talk about dry eyes, no, he can write it as keratoconjunctivitis sicca. And then the dry mouth part can be described as halitosis and dental caries. I mean, the dental caries in these patients will be extensive because, see, our bacteria has the bacteria in the mouth are kept under check by the bactericidal property of the saliva. And in this patient, what will happen is that because the amount of saliva that is produced is lesser, so there is overgrowth of the bacteria responsible for dental caries. This is itself a question from microbiology that you read, that the one of the bacteria responsible for dental caries is Streptococcus mutans, and that's because the bactericidal property is lesser, in a sense that the amount of saliva that is produced in this patient would be relatively less. So therefore, in a setting of dry eyes, dry mouth, bilateral salivary involvement with these couple of rare things also described in a question in form of RT and MPGN, you need to remember that for diagnosis, one, we need to demonstrate that the salivary flow in these patients is lesser. So the term to be remembered is unstimulated salivary flow. You also need to quantify this and answer this as less than 0.1 ml per minute is the unstimulated salivary flow definition. And I mean, the amount of salivary flow in this patient is substantially reduced, which explains why there would be development of xerostomia and extensive dental caries in these patients. Then to describe the dry eye, the amount of tear production in the lacrimal glands is lesser. So the test that he'll be describing is called as Shermer's test. In Shermer's test, you can see a marking in the filter paper, and you need to remember this value also of less than 5 millimeter involvement of the filter paper by the tear in a total of 5 minutes in at least one eye. So it may not be present in both the eyes, but yeah, because the disease will be having asymmetrical involvement, so one lacrimal gland can be involved more than other, and a lot of these patients would be having gritty sensation in the eyes or dust-like sensation in the eyes, for which you will have to put a methyl cellulose eye drops. Then we might be putting couple of stains in the eye also to demonstrate the keratoconjunctivitis sicca component. So one of the stain that we put is lissamine green, as you can see. Another one that we put is a rose bengal, which would be, as the name suggests, a rose that would be pinkish to red in color. And then we calculate what is called as a ocular or a eye stain score. This eye stain score value, if more than 5, involves, I mean, eye stain score is basically to involve, demonstrate the damage to the bulbar as well as the damage to the conjunctiva as well as damage to the cornea of this patient, which is why I was saying that there would be keratoconjunctivitis sicca. So the demonstration of this has to be there, and therefore a question may not use these classical terms like dry eyes and dry mouth. He will be using these U's. What I mean by U's is that there would be unstimulated salivary flow reduction. There would be Sharma's test that will be show less than 5 millimeter involvement of the filter paper at 5 minutes, and the eye stain score to be more than 5. There might be an alternative term written, a bit of a, I would say, a Nordic name. This is more of a term. The name we Van Bisterveld. This is more of a Nordic name. Nordic would mean countries in the Scandinavia, and the value for that score is value more than 4. So apart from use, other features that would be useful for diagnosis would be antibodies. One of the antibody that helps in diagnosis of this condition is anti-Rho antibody. The subscript anti-Rho, I mentioned the subscript numbers there also, 52 and 60 as well. So it's just a good idea to remember those numbers as well. And then the next feature to be remembered would be a biopsy finding. The finding of the biopsy that I have already written. So it would, the space is lesser at the moment. So all I'm writing is minor salivary biopsy findings, which would be in the form of that focal local lymphoid infiltrates in a labial minor salivary gland biopsy. So at the moment, what I can request you to remember is use AB. By use AB, I imply unstimulated salivary flow, then is Shermer's test, then is eye stain value of more than 5, antibody, and then minor salivary gland biopsy. The B stands for the biopsy component. And he says that anyone from use, and he says that anyone from these, and then he puts a plus in between to say that if we are having any one from their total of 5, right? Use AB is what you need to remember for the exam. And from these 5 that I've described, he says that at least 2 should be present. Those 2 would be like any one from the one, like unstimulated salivary flow is documented. That implies that there is the dry mouth component. And along with that, we can document an antibody. So if suppose I'm able to demonstrate 2 of these features, then he says that you can write on the case file as Sjogren syndrome. For the management of this condition, which can even cause metabolic acidosis and involvement of the kidney tubules, well, we will have to use drugs in the form of methyl cellulose eye drops. Then cevimeline, that's important because this is a cholinergic drug. It will improve the salivary flow. This was a question in pharmacology perspective, that what drug will be used to enhance the salivary flow. Obviously, we'll ask these patients to drink a lot of water, because when these patients will consume food, no, especially dry food items, like if you're eating biscuits or chips, they'll stick to the hard palate because saliva production is lesser. Saliva keeps the food lubricated. If you remember, like a kid, you came after playing, your mouth was all dry, and if you eat that Parle G biscuit, it will stick to your hard palate. So similar kind of presentation would be present here as well. So difficulty in chewing can be described in a question as well. Then we use hydroxychloroquine, soda bicarbonate for metabolic acidosis component. And anyway, we need to use immunomodulators since it is a immunologically mediated disease. So it's mainly, if this topic will be asked to you, it is this use AB that you have to basically deploy to remember the diagnosis of Sjogren syndrome. And well, I can say towards the end that the going get stuff, rheumat per se, is a high paying job. Why? Because it's a multi system involvement. So a guy has to be good with all systems to be good in Rumat per se. So we do have tough times, but we need to persist and push through. And this was one video where I can say that you'll have to endure the duration. Endure the data crunching in this entire duration. Unlike in neuro and unlike in cardiology, where there's a lot of logic going on, here it is more of hardcore facts. So you need to do those hardcore fact crunching so that you can hit the final ultimate goal. And as I say always, I'll finish by saying keep hammering, keep the pressure on, and you guys will do great in your careers.